My name is Alper. I'm from Istanbul, postgraduate year 4 resident, surgical resident. So I will try to present our simple study about obesity surgery and fatty liver disease. We have no disclosure. Yeah, good, thanks. As it is talked a lot of during this conference, obesity a well-known disease, and it is a metabolic disease which affects a lot of systems. So the comorbidities is sometimes more important than just BMI. So as a metabolic organ, liver is in the focus of these effects. Non-alcoholic fatty liver disease is the most common chronic liver disorder. So it is prevalent with the obesity, fibrosis, cirrhosis, carcinogenesis, and liver failure bring about it. There are several studies try to explain a relationship between NAFLD and bariatric surgery. I put some of them in the slide. Actually, I found almost 15 studies on the PubMed, but I put 3 of them. One of them is a couple years ago presented in SAGES also. All the studies have same result. NAFLD gets reduced after surgery, and some of them use biochemistry, biochemical analysis. Some of them use MR spectroscopy, but the gold standard is always liver biopsy. And it is written Transient Elastography as a non-invasive method, and this study evaluating feasibility and accuracy of non-invasive tests is prefer transient elastography as a result. So we use that. I will explain later. So actually we have a prospective ongoing study about making decision to select surgical modalities, sleeve or bypass of non-alcoholic fatty liver diseased patients, but we separated these patients, which 60 patients operated with laparoscopic sleeve gastrectomy, and we also measured their gastric specimen. So we gathered these data, demographics, anthropometric measurements, and gastric specimen measurements, and transient elastography results. That's our characteristics. Demographics is mean age is 40. Quarter of them is male, and the huge amount is female. BMI mean is 50, and there is CAP and LSM values in this line. These are explained transient elastography results. This modality is about elasticity and stiffness of soft tissues. Liver stiffness measurement is about the US waves. It is quick when the liver is cirrhotic, and it is slow when the liver is healthy, and average normal degree is 5.3. There is a scale F0 to F4, and we gathered our patients with this scale. Control attenuation parameter is another value. It says us to has liver steatotic or not. If it is about the ultrasonographic waves absorption, and it is directly proportional to liver fat level. The values is below, so if the status grade is coming S1, S2, or S3. And this is our gastric specimen measurements method. On the left side, this photo is taken right after the resection. So we measure the gastric specimens right after the resection because not let it shrink. And the right side photo is after insufflation. We place a 5 mm trocar in the most distal edge of the resection line, and we detect some points for measuring, and we measure length of long curve and resection line and tissue thickness, and after carbon dioxide insufflation, we measure the volume of the gastric specimen. And we get some results about these all are correlations about gastric specimen volume and BMI, CAP, LSM. And we couldn't find any correlation between other measurements with these values. So I put just gastric specimen volume results. So as a conclusion, NAFLD is related with higher BMI. To determine and follow up the NAFLD, previous studies showed that several methods are available: biopsy, ultrasonic blood test. Transient elastography is a non-invasive, trustful, and safe method. Also, these patients have, as we found, larger gastric volume and higher gastric expansibility. And by measuring the sleeve gastrectomy specimen, we can fairly estimate the degree of hepatosteatosis if we didn't have any preoperative, how can I say, methods. So that's it.
Great. Thank you very much.